Good afternoon and welcome to today's webinar, COVID-19 Crisis Standards of Care, Guidance for Healthcare Systems and Providers, brought to you by the Network for Public Health Law. I'm Charles Chong, the Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on our website shortly after the conclusion of today's event. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. We'll be addressing them during the Q&A session towards the end of today's event. The moderator for today's webinar is Kayleen Claridge. Kayleen is the Marketing and Membership Manager here at the Network's National Office, where she assists in the development and execution of our national marketing and communication strategies, as well as the Network's membership program. Prior to joining the Network, Kayleen worked for a nonprofit association management firm, where she assisted nonprofit scientific associations in the marketing of their memberships, annual meetings, programs, and services. Kayleen will be leading us through the rest of today's webinar, so Kayleen, over to you.
Thank you, Charles. At this time, I'd like to introduce our presenters. Dr. Dan Hanfling serves as a Vice President on the technical staff at In-Q-Tel, a non-governmental, not-for-profit organization that seeks to bring innovative technologies to support national and health security requirements. The team he works with, BNext, is specifically focused on illuminating the national security implications of infectious disease outbreaks. Dr. Hanfling co-chaired 3 Institute of Medicine National Academy of Medicine committees that developed the Crisis Standard of Care framework, and he currently co-chairs the National Academy of Medicine's Forum on Medical and Public Health Preparedness. He is clinical professor in the Department of Emergency Medicine at George Washington University and is a board-certified emergency physician practicing at Inova Fairfax Hospital, Northern Virginia's Level 1 Trauma Center. Donna Levin is National Director of the Network for Public Health Law, where she oversees organizational strategy and operations. Before joining the network, Donna spent 26 years as General Counsel at the Massachusetts Department of Public Health, where she had oversight of the Office of General Counsel and led her team in providing guidance on statutory and regulatory authority, the development of major policy initiatives of the department, and legislation affecting public health. At this time, I will turn it over to you, Dan.
Great. Well, thank you very much for the opportunity to participate with you this afternoon, and to all of those who are signing in and listening in to hear about crisis standards of care and the work that is now so front and center as the COVID-19 crisis begins to roll through cities across the United States. So I'd like to spend a little bit of time setting the table with regards to crisis standards of care, describing essentially what they are and how we developed the framework, and highlight the fact that through all our work over the 3 committees that met in 2009, 2012, and 2013, that we felt the fundamental imperative being a duty to plan, that the ethical essence of what we were contemplating, always hoping that it would never see the light of day, was based upon the necessity of having a plan and recognizing that catastrophic disaster could befall our communities and our country. So in 2009, the Institute of Medicine, now the National Academy of Medicine, issued a letter report to the Assistant Secretary for Preparedness and Response, addressing the questions about how care should be delivered in the context of catastrophic emergency, and how decisions should be made with regards to who receives care when not all patients can receive care. And the definition that we settled upon, which ended up being crisis standards of care, was that care that's delivered in a catastrophic or pervasive emergency or disaster, and it recognizes that it requires a substantial change from the usual ability to deliver healthcare. And not only is there a change in usual healthcare operations, but it's recognized that ideally these should be formally recognized by state government, and that the change in care that will be delivered will be in place for a sustained period of time. And finally, that there should be specific legal and regulatory powers and protections that allow healthcare providers to make these difficult decisions with regards to allocating and using scarce medical resources. So as a practicing emergency physician, to distill this down to plain English, what this means is that it's not just another busy Saturday night in the trauma center. It is really a fundamental change in the way that we deliver care over a period of time. And as you reflect now on what is occurring with regards to the COVID-19 virus, and with stories that we hear, particularly coming now from the city of New York, it's clear that there are communities in which crisis standards of care are occurring right now. The rationale for thinking, planning, and talking about crisis standards of care really boil down to the fact that under these circumstances, there's a tremendous mismatch between the demand for healthcare services and the ability to provide those services. And we know that to be true, especially with regards to the delivery of critical care, where very special equipment, mechanical ventilators, and other life-saving equipment is potentially in short supply. So we must be prepared to provide guidance for how to make potentially difficult decisions, recognizing that patients will have fewer choices under these circumstances, as will the healthcare providers who are in the place to have to make those decisions. And so it's important, and I think one of the key fundamental tenets of our work in crisis standards of care, that these decisions require a proactive, honest, transparent, and accountable communications and messaging capability. Because at the heart of making such difficult decisions is maintaining the trust of the patients who frontline clinicians are responsible for, whose lives they're responsible for, and also the trust of the healthcare workers who are being put in some very difficult positions now, particularly as they face their own resource shortages with regards to protective equipment. So the key messages, and there were many, many key messages, and I guess I'm highlighting two at this point in time, are first to recognize that change in the delivery of care doesn't mean that some patients get abandoned. What it really emphasizes is that all patients should receive some degree of care. And it is the intent of our crisis standards of care framework to administer the best possible care, even when resources are limited. I think the other key message, again, is to recognize that as the pandemic moves across the country, as this virus sweeps through cities, different cities will be experiencing tremendous load and run on their resources at different times. And this dynamic element is part of what we recognize to be the situation with crisis standards of care. So let me take you through a very quick history of this work at the federal level. In 2007, the Agency for Healthcare Research and Quality actually convened and issued a report on what was described then as altered standards of care. And it was really the first recognition ever that there might need to be some degree of rationing of healthcare in a large-scale disaster. And this slide depicts what I oftentimes refer to as the Goldilocks choice, that there would be those patients who are too well to actually receive care and yet might overwhelm hospitals out of fear and anxiety or concern for their own well-being. There are those on the right-hand side of the slide who are too sick to survive, and for whom the delivery of certain services might ultimately be deemed futile. And then there are those who are optimal for treatment. And this, again, in 2007 was groundbreaking with regards to the notion that that care delivery would change so dramatically in a disaster. Work that my colleague John Hick up in Minneapolis, Minnesota, and I and others were doing at the time around surge capacity planning actually is what led us towards the conception of crisis standards of care. And what we began to describe was that surge planning, the ability to surge in the demand for healthcare services, is not a static phenomenon, that it's really a dynamic process in which surge expands and forces changes in the delivery of healthcare services based on what that mismatch looks like. And Dr. Hick and others described a transition from conventional to contingency to crisis surge capacity. And I noted that in conventional surge capacity, we're probably operating under conventional standards of care. In crisis surge capacity, we're operating under crisis standards of care. And that is, in a nutshell, how we came upon the terminology and the beginning of the framework. Now, let me touch in a little bit more detail on the supply-demand mismatch. This graph comes from the 2013 report on indicators and triggers. And on the y-axis, on the left-hand side, you see that as the demand for healthcare services rises, and on the other side of the graph, as those supplies decrease because of their burn rate, because they're being used up over time, there is a transition at some point to this area under the curve that represents contingency or crisis care. And so when such time as the demand for healthcare services goes down and the resupply of resources goes up, you can exit from contingency or crisis care back towards conventional care. Let me, again, trying to distill in very rapid fashion here a lot of the work that the committee undertook. And this, from the 2012 report, essentially on one slide highlights the systems framework that we articulated. And let me point out some key features of this framework that we envisioned almost a decade ago. The first is that the foundations here are critically important. The ethical considerations and the rule of law, the legal authority environment in which decisions are taken are more important, certainly equally important, if not more important, in a disaster in which reliance on those rules and strong ethical principles are critically important. And that brings me back to the point I made earlier about being honest and open, being transparent and accountable, critically important. You see a number of steps that we put in place, and those steps actually represent the key recommendations that our 2009 committee focused on. The first being the importance of provider engagement, followed soon thereafter by community engagement. In order for crisis standards of care to really be implemented, it really requires the provider community and then the community to which we serve, to which we are delivering care, to understand these forced choices and to understand that these are very difficult decisions that take us away from our usual comfortable way of managing and delivering healthcare services. And that engagement process is critically important. And I would posit that is not too late, even now, as communities begin to see the tremendous challenges that New York City is beginning to experience. And certainly before that, what we saw in European cities, that we need to make sure that the public and the frontline providers understand that we are changing the way that we are delivering care. The third recommendation, the third step there, are the development of indicators and triggers. And we took a deep dive on the notion of indicators and triggers And in fact, in the guidance that was released in the 2013 report, we lay out across multiple domains, hospital care, public health, EMS, emergency management, behavioral health, what some of the indicators, triggers, and tactics for implementing some of those triggers would be across the domain transitioning from conventional to contingency to crisis care. And then I would just point out that there are a couple of other key elements. On the left-hand side, you see a big block focused on education. On the right-hand side, information sharing, or what we describe as situational awareness, both of which are critically important and are bridged by that top step of performance improvement, recognizing that even in the midst of crisis, data and evidence is important, and we want to try to make evidence-based decisions when we can. And performance improvement allows us the opportunity to make mid-course corrections if they are possible. Now, I missed the step before that, which are the implementation of clinical processes and operations. These continue to be promulgated and developed by the professional societies, and of course are also equally important based on their experiences, their knowledge, and the existing evidence that they have with regards to the delivery of care. And the top half of the diagram emphasizes that this spans multiple stakeholders, hospitals and health systems, the public health agencies, those who deliver care in the out-of-hospital setting, emergency medical services, and then our public safety and emergency management agencies, bounded by local, state, and federal government participation. So that, in a nutshell, is the systems framework. And I'll conclude with one last slide that is intended to demonstrate the dynamic nature within which crisis standards of care are applied. So I would highlight for you that an incident occurs, and then you come up through the arrows and essentially point your attention to the arrow, the big red arrow that points towards the right side of the slide. That and the point that makes is that as the incident as the demand and supply of resources imbalance gets skewed towards the right-hand side, the risk of morbidity and mortality increases. And our goal is ultimately to never have to enter crisis conditions in the first place. But if we do, to figure out how to push back to the left-hand side of this diagram as quickly and as expediently as we possibly can. And I would highlight for you that in the conventional response, at some point, as we begin to cross a threshold, in which case there are a shortage of resources, we begin to make adaptations, and that puts us squarely in the contingency, that middle ground, with regards to our response. And at the point in time in which we are now crossing a threshold in which those scarce resources actually have to be physically triaged, some get it and some don't. We are now in a crisis response, and we're making the difficult decisions about allocation or reallocation of resources. So with that, let me stop and pass the baton over. Well, first, let me change the slide and pass the baton over to Donna, who will take us through some of the ethical and legal considerations.
Great, thanks, Dan. That was a really good overview and helped our understanding of crisis standards of care and how important they are for the situation we're facing today. I am going to jump right in with a brief discussion of some of the ethical and legal concerns that are central to crisis standards of care planning and implementation. You'll remember these are the cornerstones on the Capitol building graphic that Dan just showed you. There is certainly a change in the legal environment that enables the transition to crisis standards of care. I'm going to start with a caveat. There's no way, even speaking New York fast as I do, in the amount of time that we have today, to cover the myriad of issues involved. So I urge you to read that very well-organized and readable 2012 National Academy of Medicine Crisis Standards of Care report that Dan has mentioned. It's great additional grounding and guidance. So here's where we find ourselves, and I'm sure you've heard and seen on the news similar discussions and headlines. At the heart of crisis standards of care is ethical decision-making. And to quote the Crisis Standards of Care Committee report, without it, the system fails to meet the needs of the community and ceases to be fair, just, and equitable. As a result, trust in professionals, institutions, government, and leadership is quickly lost. So how do we decide that care should be given, what care should be given, and to whom in times of scarcity? So some of the questions listed on this slide give you a sense of the various considerations. Is there a race for care? Is it first in line? Is there a lottery, random and ostensibly neutral? Should we be prioritizing healthcare workers so they come to work and remain well enough to care for the rest of us? What about fair innings? The young have had less time while some of us are in our 8th or 9th innings. So the committee recognized community conversations and engagement are crucial to learning what the community values are in order to incorporate and reflect them in crisis standards of care plans. And I'm glad to hear Dan say it's not too late if that hasn't been done to do some of that, because it is crucial. Okay, I'm trying to... So where did the Crisis Standards of Care Committee land? In short, the primary consideration was the likelihood of survival and benefit from treatment, and that all lives are valued equally with no discrimination based on disability, age, religion, etc. And finally, that age and disability alone should not be considered a clinical risk factor. Not advancing here. Okay. Where's my disability? Here we go. Sorry. So just this week, disability groups filed a complaint about crisis standards of care plans in Washington State, and you can see this headline, which uses the term care rationing plan. The complaint argues that the Office of Civil Rights, that the plan discriminates against those with disabilities. There may also be another complaint filed that I haven't seen yet concerning a plan in Alabama, but I have not confirmed it yet. So you can see that these issues are in play right now. So moving on to legal authority and environment, I am going to focus on a few of the many legal issues that are relevant to crisis standards of care. My focus today is primarily on authority, liability protections, and scope of practice. So when we talk about authority to allocate scarce resources, we look to federal and state declarations of emergency. They do serve to shift the medical standard for healthcare facilities and their providers to crisis standards of care through basically the recognition of the emergency. There is a March 18th executive order of the President that gives the Secretary of Health and Human Services, in consultation with other agencies, authority to determine the proper nationwide priorities and allocation of health and medical resources. Broad language, and it looks to be pointed more towards the, allocation of equipment and supplies. However, it is broad language, and it's unclear if this will have ramifications with respect to crisis standards of care. But bottom line, it is another emergency declaration changing the situational awareness for crisis standards of care. So I want to make the point here that it is ideal if there is explicit recognition and that crisis standards of care are necessary. However, it's not required. A declaration of emergency should be sufficient. What about liability? So understandably, healthcare systems and their staff following crisis standards of care plans are concerned that patients and or their families may sue them for negligence or wrongful death. So normally, a judge or jury would be determining whether the care given is the care that a reasonable practitioner would provide in similar circumstances. So one would hope that the legal standard would flex with the medical standard, finding that a reasonable practitioner would follow crisis standards of care guidance and that the practitioner was practicing under emergency circumstances involving scarcity and the need to follow crisis standards of care. So this is some assurance of liability protection, but perhaps not enough. To be clear, however, and in addition, this would not protect the healthcare worker from being sued. There are, however, an array of liability protections for healthcare workers at both the federal and state level. They depend on various factors, such as who the provider works for, whether paid or volunteer, whether or not under a declaration of emergency. And you can see crisis standards of care comes in here as one of these many protections. So to provide even stronger liability protections, state statutes and emergency declarations can explicitly tie adherence to crisis standards of care to immunity for liability. Usually that is, the exception is in cases of willful, wanton, or reckless conduct, sometimes gross negligence. So here's a good example of a state statute that does exactly that. And here are the elements in this Virginia code. There's an absence of gross negligence or willful misconduct. There's a declaration of emergency, situation of scarcity, and the inability to provide the level or manner of care that would have been required in the absence of the emergency. And so it's important to note also, I think, that this statute is in place. It stays in place, and it itself is triggered by the declaration of emergency. So it is there and at the ready when the circumstances demand. So let's turn to changes in scope of practice. To meet increased demand, it's possible to have healthcare workers at every level work to the top of their normal scope of practice, which may not be how they practiced before the emergency. So, for example, supervision and the amount of independent care that they can give can change to flex to the emergency. There can also be temporary waivers to allow healthcare providers to provide the care that is not normally within their scope of practice. Usually this is done with waivers that draw on overlaps and common skill sets between the healthcare worker's position and potentially expanding into what another certified or licensed provider could do. This was done, for example, for administering vaccines during the H1N1 outbreak. When we talk about shifting crisis standards of care, it is important to talk about the reciprocal, equitable concern for healthcare workers and protecting them from unreasonable hazardous working conditions that they are now facing with the lack of PPE in certain jurisdictions. So aside from basic fairness, there is a legitimate question of how we would fare if healthcare workers without this equipment become ill or if they feel they cannot work. And the screen shows you some guidance from OSHA that seems to indicate that they would be within their rights if they did refuse to work. So we're all hopeful that more equipment, be it gowns, gloves, masks, will be available soon. Perhaps the executive order of March 18th will help with that. And finally, I wanted to mention, as Dan did, he called it the critical essence, there is a duty for healthcare facilities to plan for emergencies, like a pandemic, that result in scarcity. So you can see there were lawsuits and large settlements that followed the lack of planning prior to Hurricane Katrina. and in part during the Ebola crisis. And crisis standards of care are, central and crucial to part of this planning. So that is it for me. And at this point, I'm going to turn it over to Kayleen for some questions.
Well, thank you both for your expertise and for this important information. We'll start the Q&A. And this first question is for Dan. Our state does not support CSC. My facility has been working on CSC for the last 2 years independently because we need to take action. How do we find outside support for our staff in following CSC when our organizational leaders are the only ones helping?
Well, thanks for the question, and I applaud the questioner for the work that it sounds like he or she has been spearheading with regards to their institution, if not necessarily working alongside other partners either in the region or at the state level. I guess what I would say is that we are in a different phase now, given that we are in a national emergency. We are operating within not just the public health emergency that was declared by Secretary Azar, but also the national emergency declared by President Trump and the invocation of the Stafford Act. And I think that changes the context in which all existing plans and current planning is occurring or has occurred. And so I would suggest that, authorities both at the local level and at the state level are probably equally leaning into the notion of crisis standards of care planning now, if they hadn't necessarily before, and that it would be worthwhile reaching back through, for example, the healthcare coalition, if one exists in your particular community, that is comprised of the hospitals, public health agencies, EMS agencies, and public safety agencies. And if not, then at least, reaching back towards the public health agencies, both at the local and state level, to coordinate the planning effort. I'll conclude the answer to the question by emphasizing that we recognized early on the importance of coordinating and ensuring consistency in such plans. And that becomes important for two reasons. One is that the public writ large, they're going to go where they think they're going to get the best possible care. And if one hospital on one side of town is doing it one way, and another hospital on the other side of town is doing it a different way, the public is going to choose which they think is more likely to benefit them. And at the end of the day, consistency, both within communities and across community lines, and within states and across state lines, is going to be very important as we face this crisis going forward.
Okay, this question is for Donna. Do CSC have to be authorized by government, or can an individual hospital switch to them when necessary?
So I would answer that explicit government sanction or authorization isn't necessary. A hospital with a plan that reaches the point where the lack of resources makes implementing the plan necessary don't necessarily have to wait for government sanction. But, when we get to this point, I think it's usually going to be the case that you're going to have the emergency declarations. We've had them now, as Dan has said, the President's dual declaration on under the Stafford Act, the National Emergencies Act, and all of the states. So I think when it's moving from normal, I don't like to say normal, Dan, but to heavy triage procedures, to this more global and recognized emergency, not explicit authorization, but I think the emergency orders basically set the stage to do this. I hope that answers the question.
And, and Donna, I would just add one more emphasis, and that is that plans are important, and the ability to say, and this really makes most sense from an ethical perspective, that you're not just randomly choosing how you engage with the crisis at hand, but that you're actually referring back to an existing plan, and that plan is open, transparent, and is and has input from all of the stakeholders, all of the participants who have a stake in the outcome of the implementation of that plan. And again, there are some communities, as we just heard from the previous question, that maybe are, planning independent of other elements whose input would be important, but it's not too late to reach out and get that input engaged in an engagement process now.
And Dan, here's another question for you. Were crisis standards of care developed to address pandemics?
Yes, so the crisis standards of care work was initially envisioned to address catastrophic health events, and we quickly realized early in our work that there were two types of disaster events that we needed to prepare for. The sudden onset, no notice event like a terrorist bombing like 9/11, or a catastrophic earthquake like as occurred in Port-au-Prince, Haiti in January of 2010. But that not all disasters are sudden onset, and some are sustained and build up over time and last for a long duration of time. And that is clearly the pandemic scenario. And so for those of you who are looking to learn more about the specific implementation of crisis standards of care planning in the context of pandemics, all three reports actually highlight both the earthquake scenario and the pandemic response scenario. And I think you'll find a lot of useful information in that context.
And for Donna, you have mentioned the importance of community engagement in the development of CSC. Do you know about efforts to engage the public?
Yeah, so sure. So as part of the work done for the Crisis Standards of Care Committee, and actually work I did for the Massachusetts Department of Public Health, its general counsel, which coincided, we conducted public engagement. We had community conversations in Massachusetts. In two very different meetings. We built on work, I believe, Seattle, King County had done work, Harris County in Texas, Minnesota, and we met and went over actually two scenarios, a sudden onset earthquake and also novel pandemic where resources were scarce. We had facilitated discussions, and really what we found was, as Dan has said, it's just absolutely key to do this. Our basic conclusions were that it really confirmed that basically a diverse group of participants were very able and willing to have the discussion, explain the situation, and I think it's a two-way street. So you get information on where the community stands in order to really inform your planning and the plans that you come up with. And it also provides a way for you to know how to communicate with the public. There may be things and considerations and values that you have not thought of. And at a minimum, I think in part might throw to you, Dan, but why it's not too late to do this now. It's certainly going to help with risk communication and that bottom line trust that is needed during the circumstances we face right now.
Yes, and in addition to the communities that you mentioned, all of whom engaged in foundational work around community engagement. Two more recent efforts, one in the state of Maryland, one in the state of Illinois, also engage participation from large, broad swaths of the community to get their sense of the difficult choices that could lie ahead in the context of scarce resource allocation. And I think the key point now being, again, emphasizing that while broad-based community engagement may be difficult in a formal sense, it's very important to listen to all those groups who have a stake in their own health and well-being. And, I would just emphasize again that the work on crisis standards of care was in part intended to highlight that there are certain groups within the population, vulnerable populations, socially or politically disenfranchised, economically burdened, who may not have as loud a voice, and that this work also needs to speak for them and to be protective of them in their hour of need. And I think that is certainly one of the key lessons that was taken from the many excellent efforts in community engagement that you cited and that I also participated in.
Right. And I would just add one more thing. So Chapter 6 of that report, the 2012 report, basically chronicles this but does more. It sort of gives you slides that you can change. It gives you templates. It gives you the two scenarios, and it gives you a way to walk through facilitated discussions, and that's all there for you to use, and it's not too late. Great. I guess next question, Kayleen.
Yes, similar to what was just discussed, the question came in, can you point to resources addressing the racial and disability-related disparities that inevitably arise? For example, the high rate of asthma in ethnic minorities.
Yeah, so that's an excellent question, and there is certainly a deep evidence base with regards to health equity matters and the types of clinical manifestations that might manifest using reactive airways disease, asthma as an example. The challenge with understanding what some of those potential morbidity or premorbid risk factors are, and applying them against what is still relatively little known about this emerging, coronavirus, is one of the challenges that we're going to face as a clinical community going forward. Because the data that we've learned thus far, much of it from the Chinese experience, and now increasingly from the European experience, particularly from Italy, suggests that there's still a lot more that we don't know about with regards to the risk factors and potential risks to certain subpopulations. And we're going to need to redouble our efforts to try to build evidence base and share that evidence base as broadly, widely, and quickly as we can. And I'll cite a case in point. And again, if you remember the Lincoln Memorial diagram, I highlighted and tried to highlight the importance of performance improvement in the context of ongoing disaster events. During the H1N1 pandemic a decade ago, we spent a lot of time focused on the use of a particular critical care scoring system to try to determine who might be best appropriate to benefit from the use of a ventilator and who might be might have less benefit from going on a ventilator. And as it turns out, that tool, the SOFA score, the Sequential Organ Failure Assessment Score, turns out not to have been all that useful. Certainly not as a discriminator, a little bit more useful as a comparator of cases, next one to the next to the next. And what we learned during H1N1 was that patients with an elevated BMI, body mass index, those who were obese, actually ended up having a higher risk of ending up with acute severe hypoxic respiratory failure requiring intubation and placement on a ventilator. But that if those patients were weaned through their acute respiratory distress, most of them did okay on the other side. So this is the particular challenge that we're going to have, particularly with some of the groups that have disabilities or other premorbid conditions. And we're going to, again, need to be very quick and transparent and expeditious in sharing information as we learn it, so that we can fine-tune the clinical protocols that we're putting in place to try to manage these cases.
And a question for you, Dan. An issue that might not be covered is when or whether to perform CPR on known COVID-19 patients. Is it reasonable to declare all do not resuscitate?
So that is a challenging question, and I know that I believe just from the media reports, which I have not really read in full detail, that this is coming up as a potential strategy. I don't think that's an appropriate strategy. And again, knowing that COVID affects all walks of life, all age groups, not just the very old or the very infirm and so on, I think makes it inappropriate to state that a blanket application of a DNR should be applied to managing these cases. I would turn the discussion and ask the question in the following manner: how can we redouble our efforts to protect healthcare workers from any inadvertent exposures if they have to resuscitate a patient who is presumed or confirmed COVID positive? And what steps can we take to protect ourselves and to protect healthcare workers in that situation? And I think, given American ingenuity and the ability to make on-the-fly decisions with regards to protection and so on, I think that we probably should be able to meet the need to manage those cases. Again, trying to make this very real. A 20-year-old who comes in CPR or who has a respiratory arrest or cardiac arrest and is presumed or known COVID positive is somebody who we should double our efforts to try to save, given the ethical principle that Donna alluded to earlier, the fair innings principle, the fact that they have the rest of their lives ahead of them. So I would be very cautious about any application of any sort of blanket decisions, particularly a blanket decision invoking DNR.
And here's a question for Donna. With respect to liability, what are some of the other protections that are in place that would protect healthcare providers in addition to crisis standards of care?
Oh, so great. So if you think about that graphic with the circles, there are a broad array of different statutes. Somewhere at the state level, there are several federal statutes and protections in place: Uniform Emergency Volunteer Act, an Emergency Management Compact for, that gives states that have signed up. There's reciprocity covered by each other's tort claims acts as people provide emergency care across state lines. There is Federal Public Readiness and an Emergency Preparedness Act. I think the key is that these cover different actors in different circumstances. Some are only for volunteers, for example, like the Federal Volunteer Protection Act. You've got there's good There's good resources. I would point you to the network's website. There's good resources up on the ASTHO website on this and also in the report. So there are a broad array of liability protections. Again, you have to be cognizant that they are limited to what they cover in each of those acts.
A question for Dan. What are your views on the appropriateness of emergency medical personnel declining to transport to the hospital likely COVID-positive patients with mild symptoms and no risk factors?
Well, you know, I think if I understand the question, teasing it apart, there are a couple of nuances. One is, you know, a refusal to transport on a part of the transporting agency. I think that is, again, that is something that at the local level needs to be discussed. And I would turn the question around and say, how can we ensure that the transporting personnel, the first responders, the emergency medical technicians and paramedics and so on, have the protection that they need to be able to manage and be in the presence of a patient with, let's say, suspected COVID-19. I think that should be fairly straightforward, frankly, and they have the means to decontaminate their ambulances afterwards and so on. But I think that also raises another question, which is, what is the role of the public now, and what responsibilities does the public have to be stewards of these scarce resources and to be thoughtful in their utilization of, for example, ambulances and ambulance transports. And again, if I understood the question correctly, you know, a patient who is relatively asymptomatic and who is otherwise not feeling too unwell probably does not need an ambulance ride to the hospital, may not need a hospital visit at all. So I would just, state again that as we march down this road towards the implementation of crisis standards of care in communities across the nation, that we also take this as an opportunity to reemphasize the message to the public, which is that they have a responsibility to maintain social distancing and to, protect themselves with physical hygiene and other measures that will reduce the spread of disease by slowing its transmission, which again ultimately is intended to decrease the number of people who all may need critical care or hospital services at the same time.
Okay, this question is for Donna. Who can expand scopes of practice? How is that done?
I think normally this would be done by waiving or amending applicable statutes and regulations. I think in most states there are boards of registration for various types of practitioners, and those regulations are promulgated by those boards, and they would be able to amend their regulations on an emergency basis. It may be in some cases that this is thought through in advance, and there's something in the regulations that gives a good, quick process for being able to do something, meet on an emergency basis as the board, as necessary, and gets this done faster rather than in the usual slow bureaucratic process.
Okay, and for Dan, would you please comment on delaying response to codes from a patient who reasonably could be saved, where the delay is taken in order to assure providers have time to don protective gear?
Would I comment on the delay? Well, again, I think this is somewhat related to the question about DNR or approach to patients requiring resuscitation. there's no question that as healthcare providers, I work in the trauma center. I mean, I'm used to rolling up my sleeves, sticking my hand in the wound, doing whatever I have to do to protect the patient in front of me, to care for the patient in front of me. But under these circumstances where the very patients and the illness that they bear puts the healthcare worker at risk, we have to take the steps, the healthcare providers on the front lines have to take the steps necessary to protect themselves, ourselves. Because if we get sick, then we're not going to be any good to the rest of our patients who are coming after, who may be seeking care. And so if there is a delay, that delay is justified in putting in place the necessary protections, donning respiratory protective devices and gowns and so on. That is, I think that is completely advisable and acceptable and within the standard of care, given the risk that this respiratory illness presents to healthcare providers.
And Donna, can healthcare providers licensed in other states be allowed to practice where they are not licensed in an emergency?
Yes, I think that, again, we look to state law, but there are statutes granting reciprocity to providers licensed in other states. And I also think, just to expand on that, during these circumstances, states also often authorize and bring in retired practitioners and afford them some requisite liability protections as well. They may not have even malpractice insurance when they come back in. I don't know, Dan, are you seeing that at all?
Yeah, so actually, yes, there has been a call for the retired and other folks in the healthcare professions who may not hold an active license to come back in a voluntary manner. But I was going to say that with the national emergency, some of the blanket waivers that were put in place soon thereafter, one of them included, at least for physicians, the opportunity and the okay to practice across state lines in the context of this emergency. So I think we're seeing a relaxation of a number of those regulations in order to facilitate access to healthcare providers where they're needed.
Oh, great.
And I think this will be our final question. For Dan, can you say more about alternatives to using SOFA scores?
I'm sorry, alternatives to using? To
using the SOFA scores?
The SOFA scores, yeah. So the
SOFA scores, thank you.
That's okay. The Sequential Organ Failure Assessment Score. So, the fact is that the decision support tools available and used by the critical care community are each in their own way incomplete or of limited utility in a prospective manner, which is what we need them for now as this crisis begins to ramp up and we see more and more cases requiring critical care. These are tools that were never intended to be used in a prospective manner. And so, I would defer the definitive answer to the professional societies, the American College of Chest Physicians, the Society for Critical Care Medicine, the American College of Emergency Physicians in particular, who are now looking at the evidence and looking at the tools that are within their reach to figure out what may be an acceptable alternative to the SOFA score. That being said, SOFA still may have some benefit with regards to comparing patients, but it certainly cannot be used to discriminate patients. And I think time will tell, and hopefully our critical care colleagues will have the opportunity to share their experiences in the medical literature so that we can learn from what their experiences are and potentially come up with a better idea of how best to steward those scarce resources, particularly life-saving resources, if we're forced to do that.
All right, thank you. I'm going to hand it off to Charles for closing remarks.
Thanks, Kayleen, and thank you both to Dan and Donna for presenting today, and to all of our attendees. Just a few quick final notes. If you submitted a question that did not get addressed during our Q&A session, we will be sending the full list of inquiries to our presenters. Also, all attendees will be receiving an email from the network with the video playback of this webinar, as well as a link to our brief webinar survey. The survey takes just 1 minute to fill out, and it provides us with some great insights, especially in regards to what topics you would be interested in for future webinars. Join us next Thursday for a webinar on COVID-19 and data sharing, where presenters will identify various federal and state laws, including HIPAA, that impact public health's ability to share COVID-19 information. Learn more about that webinar and view the network's collection of resources on the pandemic at networkforphl.org/COVID-19. Finally, registration is open for the 2020 Public Health Law Conference, where attendees will learn legal and policy tools to address fundamental drivers of inequity, promote health and well-being, and save lives. You won't want to miss it. So that concludes today's webinar. Thank you all for attending, and have a great rest of your day.